this video, we will discuss bacterial orbital cellulitis. Bacterial orbital cellulitis is a serious infection involving the soft tissues behind the orbital septum. It is both sight and life-threatening. It can occur at any age, but more commonly, it occurs in children. Causative organisms include Streptococcus pneumoniae, Staphylococcus aureus, Streptococcus pyogenes, and Haemophilus influenzae. Modes of spread. Infection originate typically from the paranasal sinuses, especially ethmoid sinus. It can also spread from preseptal cellulitis, dacryocystitis, dental or mid-facial skin infection, trauma, or any form of ocular surgery, or through hematogenous spread. Symptoms: rapid onset of pain, pain worsens with eye movements, swelling of the eye, malaise, visual impairment, double vision, and a history of recent sinus or respiratory infection. Signs: fever is common. Eyelids are tender, firm, erythematous, and warm. Periocular edema, chemosis, conjunctival injection, sometimes subconjunctival hemorrhage. Signs are usually unilateral. However, edema may spread to the contralateral eyelids. Rhabdosis is common in established infection but is often obscured by lid swelling. It may be non-axial, particularly if an abscess is present. Painful ophthalmoplegia is characteristic. Visual acuity is reduced, color vision is impaired, relative afferent pupillary defect is present. All these suggest optic nerve compression. Choroidal folds and optic disc swelling may be present on fundus examination. Complications. Ocular complications include optic neuropathy, exposure keratopathy, raised intraocular pressure, endophthalmitis, and occlusion of the central retinal artery or vein. Subperiosteal abscess most frequently located along the medial orbital wall. Intracranial complications, which are uncommon but extremely serious, include meningitis, brain abscess, and cavernous sinus thrombosis. Investigations. Tetanus immunization status should be checked in trauma. White blood cell count, blood cultures, and culture of nasal discharge are important. High resolution CT of orbit, sinuses, and brain is essential. MRI may be required in selected cases. Lumbar puncture if meningeal or cerebral signs develop. General principles of management. Hospital admission is mandatory with urgent ENT assessment and frequent ophthalmic review. Pediatric specialist advice should be sought in the management of a child, and infectious disease specialist input is also recommended. Delineation of the extent of erythema on the skin using a surgical marker may help in judging progress. Antibiotic therapy. Intravenous antibiotics are mandatory. Choice depends on local sensitivity. Ceftazidime is a typical choice, supplemented by oral metronidazole to cover anaerobes. Intravenous antibiotics should be continued until the patient has been apyrexial for 4 days followed by 1 to 3 weeks of oral treatment. Monitoring optic nerve function. Monitoring is performed at least every 4 hours, initially by testing visual acuity, color vision, light brightness appreciation, and pupillary reactions. Deterioration should prompt consideration of surgical intervention. Surgical management. Drainage of an orbital abscess should be considered at an early stage. Drainage of infected sinuses should be considered if there is a lack of response to antibiotics or if there is very severe sinus disease. Biopsy of inflammatory tissue may be performed for an atypical clinical picture. Emergency canthotomy or cantholysis is indicated in severe optic nerve compression. To summarize, orbital cellulitis is post-septal. Painful ophthalmoplegia is a key feature. Proptosis is present. Vision may be reduced. CT scan is mandatory. Hospitalize all patients.